morphology of the permanent canines. So we're still talking just about permanent teeth. So the canines are the longest teeth, the longest tooth, and the longest root in the mouth. They are the cornerstones or anchor teeth. I think I talked to you about on the canines, we try to always save the canine teeth so that, well, we try to save all teeth, but they're a very important tooth when it comes to actually like doing restorative work. They are your teeth that do your tearing, most of your tearing. That's why animals have such big canine teeth, because they're meat eaters and they tear meat off of bones and stuff like that. If you think about yourself when you eat, if you're eating something really hard like French bread or a bagel or something, oftentimes you will take it toward your canine teeth to pull, because they're a much stronger tooth than your incisor teeth, and they give you a nice even tear. They're very strong and powerful teeth. Their universal numbers are 6. The upper right canine is 6. The upper left canine or maxillary left canine is 11. The mandibular left canine is 22, and the mandibular right canine is 27. So 6, 11, 22, and 27 are their teeth numbers. Can everybody see this PowerPoint on the screen? Okay.
Yeah.
They function, they support the lips and the cheeks. So all of your anterior teeth support your lips and your cheeks. They cut, pierce, or shear food. They protect or separate the posterior teeth during mandibular movements, resulting in canine protected occlusion. So if you notice your canine teeth, they come down lower than most of your teeth, and their shape is almost more like a diamond shape. And when you chew and you move your mandible and it moves in different directions, your canines kind of help keep it stabilized. They're the longest teeth in each arch. The maxillary canine is the longest tooth in the mouth, and it has the longest roots. So it's a big old tooth. Have you started looking at radiographs, specifics on radiographs, like identifying the teeth and stuff in radiography? So if you look at slide number 3 that I'm on, and especially the lower picture, the tooth that's kind of hanging off at the left with the big long root is a canine. The ones next to it are the premolars. This is actually a premolar shot on a bite wing, on a PA, but the canine tooth, you can see how much longer that root is than the premolar roots, or even in that picture than the molar root. And on the top picture, that's a mandibular canine, and you can see how much bigger the mandibular canine root is compared to the incisors and premolars on the mandible. The incisal ridge or edge is divided into a mesial and distal cusp ridges forming one cusp. So if you look at your canine tooth, it has 2 cusp ridges that come down and form like a V. And it sits in your mouth like this. And on the bottom, it sits in your mouth kind of like this. The mesial cusp ridge is shorter than the distal. So the mesial ridge coming toward your incisors is shorter than your distal. Your distal going toward the premolars has a kind of a sharper, bigger, upward cervical edge. The mesial cusp ridge is shorter. The facial outline is a pentagon shape. So if you look at that picture, I drew a pentagon, and you can kind of see it comes across the cervical area. It angles out a little as you come down the mesial and distal, and then it forms those 2 ridges that form the cusp tip. Some people have really sharp cusp tips and others don't. I know there was a period of time, older than you guys are, or most of you guys, where they tried rounding off the cusp tips to make them blend more with the incisors. And then they decided that that wasn't right, that you needed to leave those cusps pointed because that's part of the aesthetics of the way the teeth are supposed to look. But you may see some people who have had them filed down, or they even have ground them down just from grinding and clenching their teeth. So various shapes on the canines, but by the book, the canine should have a pentagon shape. And they have a subtle labial ridge. So what that means is that if you were to take your finger and glide it over the front part or the labial part of the surface of the tooth, there's actually a ridge. So it doesn't lay flat like an incisor. It's a more rounded shaped tooth. The canine crowns, we're going to go labial-lingual. So if you looked at the canine tooth, if you tip your head back and you look at the top surface, the chewing surface of your canine tooth, if you're going from the labial to the lingual, so here's where you have to know your directions. What are you looking at when you say labial-lingual? If you're looking at the width of the crown from the labial surface to the lingual surface. So if you look at that top picture I have, the top part is the labial surface, the bottom, let me see if I can get it to, up here is the labial surface, down here is the lingual surface. Is it showing my little marker moving?
Yes.
Okay, so this is the labial surface, this is the lingual. So if you look at it from labial to lingual, you're looking at it this direction. If you're looking mesiodistally, you're looking this way, from the mesial to the distal. So the canine tooth, the labial-lingual, is bigger than the mesial distal. So it's not as wide as it is thick or deep. And even more so for the roots, like the mandibular incisors. The distal contact is more cervical than the mesial contact. So just like with when we started going to the lateral, we said that the lateral, the contact was almost up to the middle. On the canine, the distal goes higher even more, because as we move back toward the posterior teeth, the contact area shifts more cervically. So the lateral incisor would be right here, and it would be about right between the incisal and the middle thirds where it's touching this canine tooth. And then as you go back further, you can see that the contact area goes up. The distal contact is more cervical. The crown is more convex on the distal. In other words, it rounds out more. I'm going to use the term convex on quizzes and stuff, not saying rounded out, because when you take boards and stuff like that, they're not going to say rounded out. They're going to use the term convex. So it rounds out or is more, oops, didn't mean to move the picture, more convex. And then the crown tapers narrower toward the cervical end. So what that means is if you look here, see how the crown, as you go up toward the cervical, it's narrower right up in here at the CEJ than it is down here. So the tooth kind of tapers inward as you come up to the root, just like your incisors do. And then the roots are longer than the crowns. So you can see there's an obvious difference on the same tooth that the root is much longer than the size of the crown. Anybody have any questions about the things we just looked at? It's a lot of information right there on one slide. This is just another picture. This is a real tooth. This one came right out of your textbook. You can see that the mesial contact is down here. As we go toward the distal, the contact gets up more cervically or higher up on the tooth toward the gum line. And then these are your two ridges right here. The roots taper toward the apex, so they come to their cone shape, just like your incisors. They're cone shaped and they taper, become narrower as you get to the apex of the root. The proximal outlines of the crowns are wedge-shaped. So if you're sitting and you're looking proximally or between the teeth, in other words, you're looking at either the mesial or the distal, the crown outlines are wedge-shaped or an upside-down triangle. As you can see on the right here, the upside-down triangle. That's how your incisors were too. They kind of come to a point like the incisors do so that you can bite into stuff. The proximal outlines of the crowns are wedge-shaped with the lingual having an S shape. So what that means is right here, you can see that it makes kind of a curvy shape because the cingulum right here sticks out. This is the lingual side. And then the mesial CEJ has more curve than the distal, just like on your other incisors. The mesial curves down more right here than it does on the distal. On the distal, it's almost flat across. The mesial dips down into almost like a V, just like on your incisors. If you're looking at it from the incisal, so you tip your head back and you're looking at the incisal view, the lingual contour is more curved than the labial. So in other words, if you're looking at this, this is the lingual, and from here to here is more curved than from here to here. This would be your facial, or the side that you see right here. This is the lingual, and you can see how much more it sticks out over here. That's your cingulum right there, and it makes it stick out more than on the facial. The facial, however, is more rounded than your incisors are. Your incisors are pretty flat, and you can feel that if you take your tongue and you run your tongue over your incisors and then to your canine. You kind of have to stop and angle it up. And same thing on the lingual. If you can kind of follow it, the lingual of your incisors is flat, but when you get to the canine, it bulges out. It's just a thicker, more kind of almost rounded tooth. And same thing with the other teeth. They can get wear facets on the incisal edges. Those are the little shiny wear spots. The facial surface is formed by 3 lobes. So just like your incisors, the facial surface is formed by 3 lobes. Unlike the incisors, the middle lobe, so you've got 3 lobes, you've got 1 lobe here, you've got 1 lobe here, and you've got a lobe here. The middle one right here forms the labial ridge. That's the part that rounds out. That's what makes your canines stick out farther than your incisors. And you can feel that with your tongue. It sticks out farther than on your incisors. And it's more prominent on the maxillary. The maxillary rounds out more than the mandibular. The mesial cusp ridge of the mandibular canine is nearly horizontal, and the mesial root and crown contours line up. So this is a mandibular canine. And what they're saying here is this mesial cusp ridge. These are your cusp ridges. This is your distal cusp ridge. This is your mesial cusp ridge. We said the distal cusp ridges are longer, and you can really see that in this picture because this is the distal cusp ridge. It goes from the top here all the way to here, and that other little black line is the mesial cusp ridge. On the mandibular canine, only on the mandibular, not the maxillary, this mesial cusp ridge is almost flat. So you can see it almost goes straight across compared to how much the distal one slopes toward the cervical. And what that does is it makes this CEJ pretty straight right here. See how straight it is? It goes from the crown to the root, where on the other side it dips in a little bit right there. And on the maxillary it dips in a lot. You can see that it curves in a lot. Where here it's pretty straight. And that's kind of a distinguishing characteristic of a mandibular canine. Now, when I have the quiz and you're going to identify canines, and I'll repeat this before the quiz as a reminder, the canine teeth will always be just like the incisor teeth. I would always have them in the position they're supposed to be. So in other words, I wouldn't flip a maxillary over and put it like this and expect you to be able to figure out where it goes. If it's a maxillary canine, oh, stop dragging those pictures. If it's a maxillary canine, why is it doing that? I don't want to do that. It's going to look like this. It's going to be in a maxillary position. The root's going to be up, the crown's going to be facing down. If it's a mandibular, it's going to look like the picture on the right, like a mandibular tooth. I'm not going to try and trick you and have them flipped upside down. So when you are trying to identify which tooth it is, and you've got different numbers or choices, if it looks like a maxillary, you can automatically cross off the two mandibular choices. And now you've only got two choices left. Same thing with the mandibular. If you've got a picture of a mandibular canine, you can automatically cross off the maxillary and have it narrowed down to two choices. Does that make sense?
Yes.
Okay.
I have a question.
Yes.
How many lobes does a canine have? Is it still 4 or would it still be 3?
It's 4.
Okay.
Just like the incisors, it's got 3 in the front. The facial surface makes up 3. And then you've got your cingulum on the back.
Thank you.
So your maxillary cusp tip is sharper than your mandibular. So if you look at these pictures, your cusp tip right here on your maxillary is sharper than your cusp tip on the mandibular. Because that mesial ridge is almost flat, it takes away some of the sharpness of the cusp. So instead of like the maxillary comes down like this to a point, the mandibular is more like this. It's still pointed, but if you can look at your own teeth in the mirror later on and look at the pointiness of your maxillary and then how much flatter your mandibular is, you can definitely see a difference. The mandibular cusp is more obtuse or more blunt, with the mesial cusp ridge closer to horizontal. So that's what I just kind of explained. Because the mesial ridge right here is more flat, it takes away the sharpness of that cusp tip. If it came down like this, then it would be pretty sharp. But you can see on this tooth how it forms a point, and on the other tooth it doesn't. The contact areas are more incisal on the mandibular canines than on the maxillary canines. So the contacts I marked with these black lines, and you can see the contacts are more toward the incisal edge on the mandibular than they are on the maxillary. This one's on the close to the incisal edge, but this one moves up more cervically. See how that's up higher away from the incisal edge? And then the distal contact of the maxillary canine is the most cervical of all canine contacts. So as we're moving more posterior, the contacts are moving more cervically. So you can see the distal contact on the maxillary is in the middle third. So here, if you divided this into incisal, middle, and cervical, the distal contact is in the middle third. So now we've kind of moved our contacts out of the incisal third, and we're starting to go into the middle thirds. The way the maxillary canine sits next to the first premolar, it makes the first premolar has a long ridge right here too, so it makes this kind of big triangular shape. And this is just an FYI. You don't have to memorize this part, but from an aesthetic purpose, when you smile, there's that bigger triangular space, and it just gives your mouth or your teeth a different look or a prettier smile. When orthodontists used to take out first premolars, it kind of altered the shape of that triangle because the second premolar is shaped differently. And so it took away that pretty triangle and it gave them more of like a flat appearance. And that was one of the things that they noticed a lot with when people had first premolar extractions for ortho, is it flattened out the smile a little bit. The maxillary canine crown length is nearly as long as the maxillary central incisor. And the mandibular canine crown length is considerably longer than the mandibular incisor. So if you look at the maxillary central incisor and you look at the maxillary canine, you can see that the crowns are almost the same length. Now, the canine's a little bit smaller, but not much. But if you look at the mandibular, this crown is much bigger than this crown. And now, keeping in mind, when we say much bigger, we're talking millimeters, not inches. So when you're talking about dentistry, you're almost always going to be talking in millimeters. And so they're very small numbers, but it's enough that it makes a difference when you're looking at a tooth or measuring for a crown or a bridge or something. Those millimeters make a big difference. The lingual ridge is more prominent in the maxillary canine. So on the lingual, you have a ridge that goes down. It runs from the cingulum down to the cusp or the tip right there. Remember on your lateral incisors, you had your marginal ridges and then it was what they call ditched out right here. It was a fossa. It was an indentation and you can feel it with your tongue. Where on the canine, you have a ridge down the middle and it forms two fossas, a mesial and a distal. And even on the plastic teeth in lab, this is kind of hard to see, but it forms two separate fossas. The mandibular incisal ridges wear more on the labial half. So this is just talking about how they wear. This is when teeth are in absolute perfect class 1 occlusion. If you were to grind or clench, you would wear the lingual part on the upper, and you would wear the facial part on the lower because of how they would rub together right here. I don't have that on the quiz, but that's just to illustrate that. So let's look at the maxillary canine cingulum is more prominent, than the mandibular canine. So if you look at the cingulum size, here's the cingulum on the maxillary, here's the cingulum on the mandibular. The maxillary cingulum actually bulges out more than the mandibular one. Again, we're talking about millimeters of measurement here. The maxillary marginal ridges are more prominent than the mandibular. So on the lingual surface, we have the marginal ridges right here and right here. They come off the cingulum just like they did on the other incisors, but they're more prominent than they are on the mandibular. And you can kind of see on this picture, the mandibular marginal ridges are thinner, where these are thicker or bigger. And then this is your central, what am I trying to think of? This is your central ridge, your lingual ridge on the center of that canine. And these are the two fossas right here. So you're going to have a mesial fossa and a distal fossa. And on this, the mandibular tooth, you can see the same thing. Here's your marginal ridges. Here's your lingual ridge. And then you've got a mesial fossa and a distal fossa. Can everybody see that? So you probably didn't know up until now that there was that much activity going on the backs of your upper front teeth and your lower front teeth. But there's a lot of stuff to learn on those teeth. Both maxillary and mandibular canines are narrower on the lingual half. So we looked at that picture of them on from the occlusal view. Whoops, I just went past it. If you look at that, they're narrower on this side than they are on this side. If we look at it from here, both maxilla are narrower on the lingual half. So the best way I can draw this picture is if you took an orange and you peeled it, the orange is rounded, right? And then if you peel it and you try to lay it flat, it's not going to lay flat, right? Do you ever try and lay an orange peel really flat? It's kind of hard to lay it flat. And the reason it doesn't lay flat is because there's more orange skin on the outside because the orange is rounded. Another example would be if you've ever run track and you look at a track. So as you're running straight up the side here and you're coming around the bend, right? And when you're in that far lane, you have to run more out here than the person who's on the inside. Does that make sense? So if you imagine the outer lane on a track is the facial surface of the tooth, it's going to be bigger than the lingual surface. Does that make any sense?
Yeah, it does.
Okay. The cusp tips of the maxillary canines are more labial to the midroot axis, whereas the mandibular cusp tips are more lingual. So here's a maxillary canine. Here's a mandibular canine. I drew these black lines are what we would call the midroot axis. They divide the tooth in half. You can have a midroot axis dividing it mesial and distally. We've already seen that where the midroot axis divides it here. So midroot axis, all the midroot axis does is it's going to divide it in half. And so here's the midroot axis on the on the maxillary, and you can see the cusp tip is actually closer to the labial surface or the facial surface right here. See the cusp tip? It's in front of this black line. On the mandibular, this is the facial or labial surface. You can see the cusp tip is toward the lingual. Now, if you think about the way your teeth are positioned in your mouth, the lower teeth or your mandibular teeth tip a little bit inward toward your tongue, just slightly. When you bite your teeth together, your maxillary teeth come over your mandibular teeth. So the cusp tips are placed slightly more toward where they're going to be functioning. So on the maxillary, your cusp tips are functioning more labially than your mandibular canine teeth. So on the mandibular, the cusp tips are going to be more lingual. On the maxillary canines, they're more toward the labial surface. So they're designed to do their job. So again, this is a maxillary canine, and if we divided it right in half, the cusp tip would be on the labial surface. And picture your teeth in your mouth. Your maxillary canines are more labial than your mandibular canines. Whenever we're talking about positioning like that too, we're talking about class 1 occlusion. Obviously, you can have occlusal issues that cause these rules not to apply, but on a perfect class 1 occlusion, your maxillary canines would be more labial to the midroot axis on the cusps than your mandibular. Does anybody have any questions about that? Hopefully we'll be back in lab next week and we can get a chance to look at some of these things. Okay, both the facial and the lingual contours are in the cervical third for the maxillary and mandibular canines. The maxillary canine, the facial height of contour is farther from the CEJ and more prominent than the mandibular canines. So both the facial and lingual contours are in the cervical third. Just like your other incisors, the height of contour or crest of curvature, whichever term you want to use, the tooth is wider in the cervical third, meaning by the gum line, the tooth is fatter. Does that make sense? Okay, so the tooth is fatter at the gum line or in the cervical third. The maxillary canine's facial height, so in other words, if you are looking just straight at a maxillary canine here, its facial height of contour is farther from the CEJ and more prominent. So your canine tooth, and you can kind of see it in this picture here. Here's your root and your tooth, and you can kind of see how this bulges out more right here than it does on the mandibular. The mandibular is just kind of more of a sloped line, where your maxillary actually has this bulge right here. And if you feel or look at your canine teeth or feel them with your tongue, or you can wash your hands later and look in the bathroom mirror and touch your teeth, you will be able to feel that your maxillary canine, the bulge is much bigger than on your mandibular, which almost kind of blend in with the rest of your teeth. And on the maxillary canine, you can see right here is where the biggest bulge is, and it's kind of farther away from this cervical CEJ than on the mandibular, where the bulge is right almost at the CEJ, with this black line marking where the height of contour or crest of curvature is. And see how close it is to the CEJ compared to on the maxillary canine? Why do we care about this? Because when we're scaling teeth, we're going to have to make sure we get our scaler to come all the way around to right here, because the gum tissue is going to be right about here on a person. And so we want to make sure that we get our scalers all the way up there. So that's why we care about some of these contours and things like that. Both the maxillary and mandibular canine, the CEJ curvatures are greater on the mesial than the distal. So CEJ is greater on the mesial than the distal. So it's just like with your other incisor teeth. You can kind of see I marked it with a blue line. Here's the mesial, and that's the CEJ. Here's the distal. See how much flatter this line is? This one forms more like a V than this one. And then on the mandibular, same thing. On the mesial, see how this arcs up? And this one's more just kind of rounded. That's what I'm talking about the curvature of the CEJ. If I were to give you a quiz and I would ask you which one's the mesial, which one's the distal, the first thing you want to do is look at where the CEJ curves. And on a quiz or a test, all of the teeth pictures that I have, it's going to be really obvious. You're going to be able to see the difference. I won't make it like really closed. So the cingulum is often distal to the center on the mandibulars, and it's centered on the maxillaries. So if you look at the cingulum right here, and you were to divide this tooth in half right here, the cingulum is divided in half as well, because it's pretty well centered. If you were to take...
I don't know if this happened anyway. I'll start. On slide 18, you cut out before you got to like the root depressions.
Oh.
So I just didn't hear any of that.
No, I skipped over that. Thank you for... Both the maxillary and mandibular canines have a vertical distal root depression that's greater than on the mesial. So remember we said on the central incisors, the mandibular central incisors, the greatest root depression was on the mesials. So right where the two teeth are going to come together as you're crossing the midline, you're going to have your root depression right there. On the canines, both the maxillary and mandibular canines have a vertical root depression greater on the mesial. So they're going to have the same thing, only we're going to be skipping the laterals and moving to the canines, and the root depression is on the mesial, just like it was on the mandibular incisors. The greatest is on the mesial, and you can kind of see I'm sorry, it's greater than on the mesial. I said that backwards. Let me re-say that. So because I'm going, wait a minute, the root depression is on the distal, the greater root depression. So on the incisors, the central incisors on the mandibular arch had a greater root depression on the mesial. Then as you go back on the canines, the greater is on the distal. So it's kind of flipped. Think of it as flipped. If you remembered that on the centrals it was on the mesial, it goes to the distal. And you can kind of see that in that picture. Root depressions are hard to find good pictures of, but you can see how dark that center is right there. It's your root depression. Right here, it's a little bit darker than what this one is. That's your root depression. The other way you can tell is look at the CEJ. So if you're looking at this right here, there's the flatter CEJ, there's the more curved. So we're looking on this view, that's the distal. So you're going to have your deeper root depression on the distal. Sorry, I said that backwards. Okay, the cingulum is often centered. So on this one, if you slice the tooth in half on the maxillary canine, you're going to have the cingulum pretty much split in half. If you do that same thing on a mandibular canine right here, and you split it in half, you have a little bit more, I skipped over the marginal ridge. I'll get back to that too. The distal half of the labial surface of the maxillary canine crown is more prominent. That's not what I was trying to look at. Versus the maxillary canines. So when you're looking at this being split, the marginal ridges are right here. And I've got one lined in red and the distal one is in yellow. Can everybody see that okay on their slides? So okay, so the cingulum, often distal to the center on the mandibular canines versus centered on the maxillary. So the mesial marginal ridge appears longer than the distal. So if you look at this, the mesial marginal ridge appears longer than the distal. See how long that red line looks compared to that yellow line. It's more noticeable on this one. Here's the mesial marginal ridge, and it's longer than the yellow distal. This one's a little closer, but still longer on the mesial. Distal half of the labial surface, so the distal half of the labial surface. Whenever you see something like this, first thing you want to do is stop yourself and break it down. Distal half of labial surface. Whoops, don't move. I don't know why these pictures keep moving. What am I doing? All right. The distal half of the labial surface. So we're looking at this right here where this blue area is. Of the maxillary canine crown is more prominently concave. So if you look at this blue line I drew, see how it dips in almost like a slide? Where on this one, it's pretty straight across. Can you see that? Yeah. So sometimes as you get closer to the CEJ, you will see a little bit more calculus right there. Especially in a person who doesn't have the best oral hygiene, because most of us can brush those teeth fairly well. They're pretty easy. They're right in the front of your mouth, but not everybody. Or if they just haven't had their teeth cleaned in a long time, like we're going to see a lot of those patients in clinic. This just kind of illustrates the same thing. The distal half, see, this is a real tooth and it has that kind of concaved area right there, or that little slope in it. Another way you can identify a tooth on a quiz, if you're looking at the occlusal, you can see that little slope right there, and that's the distal side. And that's the end of the presentation. So I know that's a lot of information to kind of absorb. So what I would recommend is go back through each of the slides and make sure that you can follow the text and the pictures and see what we're looking at. If you are stuck on something and the picture just isn't doing justice for you, again, you can use dental light, click on one of the canine teeth, it'll come forward by itself and you can rotate it around with your finger or with your cursor and view it from different views. If that isn't helpful, then Google some teeth and look at that. If you Google mesial marginal ridge on a canine, you'll get a whole page full of pictures of what the mesial marginal ridge on a canine is supposed to look like. And then you can kind of see from there what we're looking at. Some are more noticeable than others. So play around with whatever you need. If you still don't get something or still having problems, let me know. Again, hopefully we'll be back in lab next week and we can look at the teeth on the plastic models. So let's take a short 10-minute break, come back at 9:55 and we'll review for next Tuesday's quiz.
So this quiz for canines is next Thursday, correct?
Correct. So Tuesday's your skeleton or skull, I guess it would be skull anatomy, and Thursday's the canines.
Okay.
So we'll tackle them one at a time. Okay, so before we start, somebody had a couple of questions about the mandible on the homework assignment. So can you go back through which ones you had the question on? I don't remember who it was that asked the question.
It was me. Sorry, I had to get it out.
Oh, that's okay.
It's hard for me to tell. 1 and 16 look really similar to me.
Okay, so 1 is pointing just to that top part, and 16 is what the whole thing is called.
Oh, wait. Sorry. I mean 1 and 14.
Oh, okay. So 1 and 14, if you mix them up, that's okay. So number 1 is pointing to just this part. Let me see if I can get that little thing back up here again. Can you see the arrow? Is this part right here. And 16 is just the top, 14 is just the top surface.
Okay. And then I also felt like 4 and 18 were similar.
So yeah, they kind of are. So number 4 is pointing to this area right here inside. The inside of this area right here is where the inferior alveolar nerve runs. So you can find that in your book. So number 4 is holds the inferior alveolar nerve. And 18 is this like ridge, just the hard bony ridge right here. So this one's an actual like opening, long, narrow tube-like opening that holds a nerve. And this is just the bony ridge right here, which is this bony ridge, same bony ridge right here, but it has different names. One because it's on the outside and the other one it's on the inside, or the external one versus the internal one.
Okay.
Does that answer all of them?
I
Okay.
actually have a question on the same thing.
Okay.
It's for the inferior view. I was confused on 3 and 13.
All right, hold on. A couple of people are trying to. Okay. 3 and 13 on the inferior view of the skull?
Yes.
Okay. Let me get to the. And which ones was it?
3 and 13.
So 3 is pointing to there's 2 walls or plates, and then there's an area between the 2 plates, like an indentation or a depression. So 3 is actually the plate, and 13 is the depression between them.
Okay, so 3 is the depression, you said?
Yes. Let me just double check that. Hold on. Hold on a second. Let me double check that. And I'm sharing the screen here. Inferior view. 3 is the plate, and 13 is the depression. So 3 is actually the bone, or the part of the bone. And then 13 is like a hollow depression.
Okay, thank you.
You're welcome. Anybody have any other questions on it? Okay. So what we're going to do then is I want you have a handout. Let me see if I can get that close. That looks like this. It starts out with skull bones and it says 22. This handout is in your module.
We can't see the handout.
Oh, because I'm not sharing my screen, probably. No, I am sharing the screen. So you can't open it on Canvas?
All we could see was that PowerPoint you were just looking at.
Okay, can you open it on Canvas? There's a handout and it says skull bones at the top of it. And it's in the modules under 3.1, I believe. Let me just double check where it is. Nope, it's under 2.1. It says Chapter 3 Study Guide Skull Bones .doc.
Yeah, we have that.
Okay, so open that up, and what we're going to do is we're going to go through it and talk about each one of these things, and I'm going to show you them to you on the skull. When you are studying for next week, open this handout. Look at different views of the skull. So you can look at the ones I put in your homework assignment. You can Google some other ones. I would recommend using the KenHub and pulling out the bone and seeing if you can locate these structures. So like if you look at how I've got the handout separated, it says frontal bone. And so you can click on the frontal bone on KenHub and it will highlight in green the frontal bone. And so you can locate these different things. Now, KenHub's going to have more anatomy stuff than you need to know because it's made for other courses as well, not just for this particular course. So it will have stuff that you don't need to know on it. Don't worry about the stuff that you don't need to know. The ones you need to know are the ones I have listed here. And so that's why it's important to follow this handout or you're going to be studying way more than you need to study. So get this handout out and look at different pictures that you have available to you, whether it's on KenHub or whether it's other pictures. Now that we can open YouTube videos, you can go back and look at the videos. Try to find all of that, the landmarks on other views of the skull and stuff like that. Don't just rely strictly on what I have. Also, there's, I think those YouTube videos that I put in Canvas, you weren't able to open. And so I will load those into the YouTube, my YouTube channel, and you can look at those as well. And they go through the different skull foramen and give you some little mnemonics to memorize them. But you're probably going to have to just kind of go out there and find things that work for you. But I'm going to show you all of these things on the skull. Everybody has a different way of memorizing things. And so it's probably, like I said, best if you look at several different options so that you can find what works for you. So we're going to start with the skull and the frontal bone. So on the frontal bone, put your skull head together. There we go. The frontal bone is located right here. It's this big round bone that forms your forehead. It forms your forehead and the superior parts or the upper parts of the orbit. So right up in here, this is all your frontal bone. Can you see the skull?
Yes.
Okay, that's all your frontal bone. So as far as the quiz questions, I could ask you something like, what bone forms the forehead and the superior parts of the orbit? And the answer, one of the choices would be frontal bone. So that's kind of how the questions might be worded. So when you're looking at this study guide and there's text on a description of something, you're responsible for knowing that text because the quiz questions are all going to come from this study guide. So the entire quiz, even down the road on your midterm and your final, you'll have a study guide. The questions are going to come right from your study guide. So that's why I said if you were looking at some other resource and they talk about other things and it's not on your study guide, then don't worry about learning it because they're going to go through a lot more anatomy than we need to know for our purposes. So you've got your frontal sinuses. Your frontal sinus is right up here. It's like right in the middle of your forehead. You've got your supraorbital ridge. This right here inside your eye area, and you felt this with your fingers before, that's your supraorbital ridge. Supra being the top, it forms the orbit, the top part of the orbit. Right inside there, there's a little area, a little notched area, and you can kind of feel it if you press on your own supraorbital ridge. Right about here, there's a notch, and that's your supraorbital notch, or foramen. It's actually a tiny little hole. So you can feel that on yourself. It's on the ridge. And then you have your lacrimal fossa, which houses your lacrimal gland. And that would be right about in here. And you can feel on a skull, it dips in right about here. Then you've got your occipital bone. We're going to rotate our skull around. Our occipital bone forms the posterior part of the skull. So you've got the very back of your skull forms the occipital bone forms. You've got sutures. Does anybody remember what this serrated looking suture is right here?
Is that the mid-sagittal?
No, it separates your parietal bones from your occipital. The mid-sagittal separates your two parietal bones. This one kind of forms like an arch, and it separates the parietal from the occipital. Starts with an L.
Lambdoidal.
All right, there you go. So you've got your foramen magnum, which actually sits on your occipital bone. Your foramen magnum is this big center hole. You've got your occipital condyles, which sit right next to it. And your occipital condyles are the ones that articulate with your vertebrae, with the atlas. Does that name ring a bell? And then you've got your hypoglossal canal. So your hypoglossal canal is right on the sides here, inside. It's really hard to see. Let's see if I can get it. It's right here inside the skull, if you can see that. That's your hypoglossal canal. And I am going to take just a brief second here. I will be right back. My computer is running out of battery, so I'll be right back. All right, back in business. Okay, so those are the only three things that you need to know that are located on the occipital bone. Then we have your parietal bones. There's really nothing on the parietal bones that you need to know. The parietal bones are located right here. On the top, they form the top part of your skull. There are two of them. They are separated by the sagittal suture, and they are usually covered with hair. Then we've got your temporal bone, which is kind of a complicated little bone. So they form the lateral walls of the skull. So again, on a quiz, if I were to ask you what bones form the lateral walls of the skull, the answer would be temporal bones. There are two of them, and they're right in the temple region. So think about on the side of your head. On the temporal bone, you have your external acoustic meatus, which is your ear, the inner ear here. And then you've got, which is right here, sorry, your external acoustic meatus. You've got your temporal process of the zygomatic bone. So the zygomatic bone is right here, and your temporal process is right here. So it's on the zygomatic bone, and it's where it meets the temporal. So the temporal process of the zygomatic bone. You've got the zygomatic process of the temporal bone. I put them together just because it's easier to remember. They form the zygomatic arch. So remember, of the means on the. So if you're talking about which bone of the temporal bone is on the temporal bone, and the zygomatic process would be this right here. They are fused together by a suture. You probably can't see, I can see it, but you probably can't see it from there. But there's a suture right here that fuses them together. And they form the zygomatic arch. Anybody have any questions on that? Okay. It says next to it on the handout, squamous. So the temporal bone has 3 parts to it. And you've probably read about that in your text. There's the petrous. Does that ring a bell? All right, I'll talk about those a little later. I don't want to get sidetracked here. But the styloid process, if you rotate the skull up like this, the styloid process is this sharp, spiny thing. And then next to it, and more lateral or away from the midline, is the mastoid process. And the mastoid process is actually kind of looks like a bunch of little holes. Looks spongy almost. That's the mastoid process. And then right between the two of them, you have the stylomastoid foramen. I don't know how well you can see that, but there's a little hole between those two. So you've got styloid process, mastoid process, and that little hole right in between is the stylomastoid foramen. The stylomastoid foramen is where the 7th cranial nerve or facial nerve enters the skull. Then we've got the foramen lacerum. We're going to go through the 4 foramen in a minute. The carotid canal, the jugular foramen, and the internal acoustic meatus. So let's find all of those. If you open a picture, let's see, open your book to, do you have your textbook handy?
Yeah.
Okay, so let's open our textbook onto page 45. This is going to be hard to see with me just holding the skull up like this. So I want you to have actually a picture to look at. So this is what we're looking at right now. And there's the video the YouTube video, I don't know if any of you found the one that I posted that you couldn't open. And I said if you just cut and paste the URL into a search, it'll find it. I don't know if any of you were able to do that or even tried to do that, but I'll post it so you can see it. It's an excellent video to show you these different foramen, and it gives you a little mnemonic to memorize them. It's really great. So you've got your foramen spinosum is a tiny little one. It's this little tiny hole right here in front of my finger. Can we see that? Kind of, maybe?
Yeah.
Right above it, this bigger, more rounded one right here is your foramen ovale. Your foramen ovale, they're actually on the sphenoid bone, but this foramen ovale is where the mandibular division of the trigeminal nerve passes through. And when we get to nerves, you'll know the importance of that. And then we've got the carotid canal, which is located right here. So there's a hole, and then there's this like indentation. That's the carotid canal. That's where the carotid artery passes through. You've probably all heard of that. The bigger hole that's closer inside is your foramen lacerum, or lacerum, however you want to pronounce it. And like I said, there's a better picture of these, or a better video of these that you'll see when I post it. And then you've got your jugular foramen, which is located right here, this kind of wonky hole. And that's where your jugular vein passes through. You've all heard of your jugular vein. The foramen magnum, of course, is the big one. Let's see, what else do we have here? Okay, so now let's look at the sphenoid bone. So the sphenoid bone is located in the midline, and it's the most complex bone. It has a lot of stuff going on in it. That's why it's so complex. It's in the midline of the skull. So here's the skull, and your sphenoid bone is this bone right here that forms like a butterfly shape right here. So you can see it's right in the middle of the skull. And let me get the colored skull, and I can show you. So it would be the one in red. And you can see it kind of looks butterfly shaped. But that's what the sphenoid bone looks like. So on the sphenoid bone, let's see if I've got it where the next good picture is. Let's see. So on the sphenoid bone, we'll hold it like this. You've got your optic canal and foramen. So your optic canal is right here. So you've got these two little things that stick out. Your optic canal and foramen is right here. So if you were to take this and follow it through, it comes into the orbit area, and it would be this little hole right here in the orbit. That's your optic foramen and your optic canal, and it carries your optic nerve and blood supply to your eyes. Then you've got your superior orbital fissure. So I'm sorry, do you have a question?
Can you show us the front view of that again?
Yeah, let me see. I don't have anything I can stick through there, but from the frontal, let's see. Right inside, can you see that little hole on the inner side?
Oh, yeah.
Okay.
Thank you.
So that's your optic canal and foramen, and so it supplies nerve and blood supply to your eye. And then you've got your superior orbital fissure. It's this long slit-like when you look in the orbit. If you flip it over, you can kind of see my finger in there, right? Right there. That's the superior orbital fissure. It would be this right here, this like slit. A fissure is like a slit. Can everybody see that?
Yeah.
Okay. Your pterygoid canals are going to be located. Let's see if I can find a good picture of that one. Some of these are better looking at different views. Well, they don't have a good picture of the pterygoid canals. Okay. So, oh, there's a pretty good picture.
It just doesn't have it labeled.
What's that?
On page 48, it shows it just doesn't have it labeled.
Okay, on page 44, the bottom picture shows them pretty good. So they're going to be right in here. I don't know how well you can see that, but right here are your pterygoid canals. And then you've got your hamulus. So these are your pterygoid plates. You've got your medial pterygoid plate and your lateral pterygoid plate. So medial is closer to the center, lateral farther to the sides. You've got your pterygoid fossa right in the middle. And your hamulus is on your medial pterygoid plate, and it's this little kind of spiky thing at the end. Let me see the color. It's more noticeable on the colored skull. Let me show you that one. So you've got medial pterygoid plate, lateral pterygoid plate, pterygoid fossa down the middle, and this little spiky thing right here is your hamulus. It's on the medial pterygoid plate. And when you look at the description of it, it says that it is the most inferior, When you're holding the skull up like this, it doesn't look inferior, right? It looks like it's at the top. But the skull actually sits like this. And so if you look at the skull in the position it's supposed to be, that's the most inferior part. Can everybody see that? So that's your hamulus right there. It's hard when you're rotating skulls all different directions. Let's see. What else do we have?
So do you think that KinHub for memorizing like where everything's at will be the best option since we don't actually have a skull to look at?
Yes, I do. It's going to have everything, like it's got stuff in color. It actually, there's a video that you can listen to, and then you can click on text and it has the text to the video. So if you heard something or you wanted to go slower or something like that, instead of like stopping the video, you could read the text first and then listen to it, or vice versa, listen to it and then read the text, and hopefully it'll make more sense when you combine the two together so that you can see everything clearly. But it's an excellent way to view things and explanation for it. I believe you can look at each bone separately. And like I said, they're going to go over, when I watch the videos, it's been a couple weeks now since I watched them, but when you watch them, it's going to go over some stuff that we don't know or don't need to know either. That's why I said make sure you have your handout with you and jot down some notes and things like that while you're listening to it. And you can always stop it, or you can always go back to the text and write what you want to write. Excuse me. Okay, so we did the foramen spinosum ovale and rotundum already, but just to kind of review them again, we've got, let's see, let's look at page 45 again. You've got the foramen spinosum is that little tiny dot right there. So if you go to the foramen ovale, it's the big oval one, and go just slightly more lateral, there's a tiny little hole. And I think I showed you on this skull too. There's the foramen ovale is the big oval, hence the word ovale. And then right below it, that little tiny one is the foramen spinosum. So just kind of go a little bit lateral to it. And then you've got, if you can see, where's the next picture? If you want the other foramen, the better view is on page 46. So you've got your foramen ovale is the big oval one. It looks more oval from this view than it did the other, but here it is. It's the foramen ovale. So I always say kind of locate the foramen ovale. And then from there, the foramen rotundum is going to be tucked underneath here. So the foramen rotundum is like right here. So when you're looking at the foramen, you've got your optic foramen, and then you've got your foramen rotundum, which is kind of hid underneath. And then your foramen ovale is the big one off to the side. Foramen spinosum is the little guy just lateral to it. And the foramen lesserum is this other big one right here that's closer to the midline, or closer to the middle. And there's a video, the YouTube video I'm going to post on my YouTube channel, is going to use rolls, R-O-L-S, to memorize it. And it will show you how to find them. Rotundum being the top one, and then ovale, R-O, and then you're going to jump inside to lesserum, and then S to spinosum. So right in that little area, you have 4 very important foramina. The foramen ovale is where the mandibular division of the trigeminal nerve comes through, and the foramen rotundum is where the maxillary division. Those are going to be really important for you to know when we do nerves, because when you're studying maxillary mandibular nerves on teeth, it's kind of good to know where they came from. And then you've got your lesser wing of the sphenoid bone, which is up on top, and it's smaller. Your greater wing, on this one, your lesser wing is on top, it's got these two little things right here attached. That's your lesser wing. Your greater wing is the bigger bottom part, which is kind of easy. Your inferior orbital fissure, let's see if I can find a good picture of your inferior orbital fissure. Trying to find these things on in your textbook so that you can go back and look at the pictures yourself. They don't have the inferior orbital fissure marked on any of these. All right, let's see. Yeah, they don't have the inferior orbital fissure marked on these. I know I have the inferior orbital fissure on your PowerPoint though. So when you are doing your PowerPoint homework, look where the inferior orbital fissure is. Let's see if I can show it to you. It's best if you can see it through the eye, through the front, but you've got the superior orbital fissure and the inferior orbital fissure. And the inferior orbital fissure comes through, you can see it like right here too. So here's the inferior orbital fissure. I don't know if you can see where my finger is, but if you look inside the orbit, you've got the superior and the inferior, and they form like a little arrow shape pointing toward the nose. Can you see that in the skull? Can anybody see that?
Yeah.
Okay, so that they're slits though, they're fissures, and you can see them through the orbit area better. They're actually on the sphenoid bone, but you can see them better from the orbit than you can from the sphenoid bone. And then the last one on that list, the sella turcica. Let me see if there's a good picture of the sella turcica on here. Hopefully you guys are writing some of these pages down or using your book for this. And all right. I know it's got to be in your book somewhere for you to look at it, but the sella turcica is actually this little area right here, and I've got it on the PowerPoint. I don't see a picture in your book, but I'm just flipping quickly. There should be one in your book somewhere that shows it, but that's that little area right in there. And again, it's right like this. This is a little saddle shape. When you watch that video too, he talks about it in there. The ethmoid bone is located in the midline as well, and it joins the vomer. So the ethmoid bone you can best see in here. It's white. It's not a very big bone, but it's joined with the green bone, the vomer. So you can kind of see, if I flip it up this way, you can see the green vomer, and right inside there's the white ethmoid bone. So it's a center midline bone as well. And the only things you really need to know on the ethmoid bone is it has the superior and middle nasal concha. The superior you cannot see. The middle one is this white one up on top here, of course, with the bottom one being the inferior, but this middle one is this white one. And then you've got the perpendicular plate of the ethmoid bone. So some of you may have heard of this before. Perpendicular means it forms a T with the surface. So perpendicular runs vertically, and it usually forms a T with a surface. So the perpendicular plate is this white plate. Can you see inside there that white flat? Remember, a plate is a flat surface. So inside the nasal area, there's a white flat plate that runs perpendicular down the middle. Can everybody see that inside the nose? I don't know which way, if I'm holding the skull in a good position or not. Somebody, can you see that?
Yeah, I think so.
Okay. And the nasal septum then is down the lower half of it. So the perpendicular plate's the upper part and the nasal septum is the lower part. And in your textbook, there's a pretty good picture on page 56. So you can see that the perpendicular plate is this big white part. Your vomer is the green part. Your nasal septum is I guess you could say the whole thing is considered the nasal septum. And it shows a picture on page 56 of that different view. It shows the middle nasal concha, the perpendicular plate, and the vomer. And they form those two, perpendicular plate and vomer, form the nasal septum. Then we've got the facial. Does anybody have any questions about these skull bones? Okay. Then we've got the facial bones. The vomer is very small. It forms the posterior part of the nasal septum inside the nasal cavity. So the vomer is the green bone inside the nasal cavity. It's kind of an uneventful bone. The lacrimal bone forms the anterior or front medial inside wall of the orbit. And it's these little red bones right here. The nasal lacrimal duct sits right inside. There's a groove right here that I can feel with my finger. You can probably see it. That's where the nasal lacrimal duct sits. So your lacrimal gland sits up in here, but your nasal lacrimal duct is right here. And this is where your tears come out. Right here. Then you've got on your nasal bones, they form the bridge of your nose. They're these little purple bones right here. And the nasion is right where the nasal bones meet the frontal bone. This little suture right here is called the frontonasal suture. In other words, it's where the frontal or frontal bone meets the nasal bones. And the piriform aperture is this triangular opening where the nose is. So it kind of like marks the bony structure or housing of the nose area, with the rest of it being cartilage and tissue, soft tissue. And then of course your nasal concha, superior and middle come off the ethmoid bone. The inferior is its own bone. So let's drop down to number 4. The inferior, they form the lateral walls of the nasal cavity. So you can see they're on the outside or lateral walls of the nasal cavity. Then you've got your zygomatic bone, which help to form your cheekbones. What bone does the zygomatic bone meet with to form the cheekbone?
The temporal?
Yes, yeah, good. All right, and they form the cheekbone. The zygomatic bone helps to form the lateral wall of the floor of the orbit. So if you look at the orbit, right in here, lateral wall would be the outer wall, and the floor, or the bottom, you can see it's purple. That's the zygomatic bone that's helping to form that. Palatine bones. So flip it up to the palatine bones. You have the 2 purple bones right here. The palate is made up of the horizontal plates of the palatine bone. So of the palatine bone, these are the horizontal plates right here. They form the posterior hard palate. They're these 2 little purple bones. They run more horizontally because they're short and they're wide. There's 2 of them that fuse together. Does anybody remember what that suture is that runs along the middle of the palate? Somebody guess?
Palatine suture.
Median palatine suture. So it runs through the middle of the palatine. These are the horizontal plates of the palatine bone. And then we've got the palatine processes of the maxilla. So the palatine processes are actually on the maxilla, or of the maxilla, meaning on the maxilla. And this is what forms the anterior hard palate. Together they form the whole hard palate. So remember that these bones, all four of these, are part of the hard palate, not the soft palate. Because oftentimes students get confused and they think this yellow is the hard palate and this purple is the soft palate. And it's not. It's all the hard palate. Then we've got the foramen. So we've got the greater palatine and the lesser palatine. So if you go back to where your molar teeth are and you follow in, you're going to see these holes right here. Can you see those holes? Those are your greater palatine foramen, and it's the opening for the greater palatine nerve and blood vessels. And then down below it, you've got a tiny little hole right in here. Hopefully you can see that. That's your lesser palatine foramen. And it's the opening for the lesser palatine nerve and blood vessels that serve the soft palate and the tonsils. We do not pay any attention to the lesser palatine foramen. It is not a part of our lives. The greater palatine foramen is important because that nerve numbs the inside of the palate up to the canine area. So it does this inner part right here. And your median palatine suture is the suture that runs down the middle and separates all the way down, separates the palate into two sides. The transverse palatine suture runs horizontally or transversely, and it runs this way, separating the palatine process, or horizontal plates of the palatine bone and the palatine processes of the maxilla. So they form, those two sutures form a T and separate the palate into four bones. Does everybody get that? The median palatine suture, when you look in somebody's mouth, the soft tissue covering is called the median palatine raphe. Then we've got the maxilla. The maxilla is the upper jaw. It actually is two bones that have fused together, called the intermaxillary suture. It holds the two maxilla bones together. The alveolar process of the maxilla is this part right here that covers the roots of the teeth. So a quiz question might ask you, what bone houses the roots of the teeth? And one of the choices would be the alveolar process of the maxilla or the alveolar process of the mandible. Alveolar process is the bone that covers the roots of the teeth. So when Professor Bowles is showing you radiographs, she's probably talked about alveolar bone. And that's what we're talking about, is this bone that covers the roots of the teeth. It's called the alveolar bone. You have your canine fossa and your canine eminence. The canine eminence is the bulge part over the canine tooth, and you can see that on the skull, how it bulges over the canine tooth. And the canine fossa is just posterior and superior to each of the maxillary canines. So right in here, there's a little indentation on the, just past, when you go more posterior from the canine eminence is the canine fossa. So basically the root sticks out, and then where it dips in as you're going toward the premolars, that's your canine fossa. And that's where you're going to give your ASA injection. And then you have your incisive foramen. So we're going to rotate the skull back up to the inferior view. And your incisive foramen is this foramen that's right behind your two front teeth, and it carries the nasopalatine nerve. So that's the nerve that's going to numb the palatal part from canine to canine. The greater palatine nerve is going to numb this part. The nasopalatine nerve numbs this part. Then you've got your infraorbital foramen. Your infraorbital foramen we already kind of talked about. Your infraorbital foramen is right here. It's this little hole that's right underneath the cheek, right here. There is an injection that can be given called an infraorbital injection, where instead of going up and giving an ASA and stopping with the needle here, you would go up all the way until you contacted that foramen all the way up there. And if you numb that foramen area, it will numb all of the premolars and anterior teeth. We do not teach that. So we won't be doing those in clinic. However, sometimes you accidentally do that when you're learning and you go too far up with the needle. And you'll know when you do it because the bottom of the patient's eye will get numb too. So their eyes keep tearing. It's kind of uncomfortable. It happens sometimes by accident though. And then you've got your maxillary tuberosity, which is this bony area right here behind the most distal part of the maxillary arch and teeth is right here. And then we're going to look at the mandible. We've got a couple of different mandibles here. So the mandible, we have the ramus, which is this part right here, this flat part. You will need to know that the mandible is the only freely movable bone of the skull. In other words, it moves on its own. You've got the ramus. You've got the alveolar process contains the roots of the mandibular teeth. So it would be this area right here where the roots of the teeth are. Then you've got the angle, which is exactly what it sounds like. It's the angle where it bends. You've got the mental foramen. The mental foramen is this little hole right here. It is on the lateral surface. So if you hear the foramen on the lateral surface, that would be the surface away from the midline. Your mental foramen is where your mental incisive nerve and blood vessels pass through. It's located at the, usually around the base or the root of the second premolar, but it can move, it can be in like slightly different areas on different people, as sometimes it's a little more anterior. But it's going to be in that general vicinity, and you will be able to locate it on an x-ray. Your mental symphysis is this faint protuberance that represents the fusion of the mandibular processes. So right here, running vertically, there's a little kind of a place that sticks out, or protuberance, and that's where the mandibular bones fuse together to form one. Your mental protuberance is this chin, basically, right here. Then you've got your body of your mandible. Your body is inferior to the mental foramen. So this part right down here, you find your mental foramen. Right below it, this hard part right here is the body down here. Then you've got your external oblique line. Your external oblique line runs right down here. You can kind of see as it comes off, it basically the coronoid notch is right here. And it would be this area that runs more toward the anterior below the coronoid notch. Can everybody see that? So it would run right here. That's your external oblique line. And then you've got your coronoid process, which is this thin anterior border right here, which contains the coronoid notch. And the coronoid notch is what you're going to feel for when you're giving it an IA injection. Now, I can't tell you to stick your fingers in your mouth, but if you were to do that, you would be able to kind of feel that little notch on yourself. You have to press kind of hard, but you can feel the little notch. And when you're giving an injection, the first thing you're going to do on the patient is you're going to feel around for that notch, because that's your landmark. The condyloid process, by the way, let me just turn your book to the page we're looking at so that we can all, the condyloid process contains the neck of the mandibular condyle and the mandibular condyle. So this is the condyloid process right here. And then you've got your mandibular notch, which is this dipped down area right here. Your retromolar triangle is just like your maxillary tuberosity, but it's on the mandible. It's the area right behind the very furthest molar, most distal, most posterior molar. It's kind of flat, unlike the kind of spiky one on the top. This one's flat. Genial tubercles are on the lingual, right where the incisors are on the mandible. You will be able to see them sometimes on a radiograph. There'll be little white dots. Those are your genial tubercles. The muscles to the tongue and the floor of the mouth, some of them attached to those genial tubercles. That's what they're used for. Then you've got your mandibular foramen. Don't get it mixed up with your mental foramen. Your mandibular foramen is located on the inside, and it's right up here. It's this little hole right here. Can you, oops, somebody's trying to get back in. It's this little hole right here. Can everybody see that? And that's the opening where the inferior alveolar nerve is going to pass through the mandible. The inferior alveolar nerve is the one you're going to give the injection to. So when you're feeling for the coronoid notch, it's going to take you, believe it or not, in proximity to where the inferior alveolar nerve is. The mandibular foramen has this little piece of spiky thing sticking out over it, and that's called your lingula. And it's an attachment for a ligament. And coming down from that, right here, you can kind of see there's a line